Well, hello everybody, and thanks for joining this series, the seminar on brain tumors through Weill Cornell Medicine. My name is Dr. Rohan Ramakrishna. I'm an associate professor here at Weill Cornell in the Department of Neurologic Surgery, and recently now the new chief of neurosurgery at Brooklyn Methodist Hospital, which is part of our growing network within the region. I'm really happy to be with you today. And, really this is a conversation, an update for both patients and doctors about where we are in brain tumors in 2020. It's a subject that's a little enigmatic and can take a long time to wrap your head around. But there's some really exciting developments both in the science of brain tumors as well as the treatments that we have available. So in terms of what we're going to talk about today, we're going to spend most of our time talking about gliomas and brain metastases. But at the very end, we'll be spending some time on meningiomas and pituitary disease, understanding that in our short amount of time, we can't really cover everything in extreme depth, but we can provide you with some information, which I hope you'll find useful. So starting with gliomas, gliomas are a primary brain tumor. It's a tumor that starts in the brain, doesn't typically spread to other parts of the body. And it turns out gliomas actually refer to a number of different diseases. There are the brain cancers, the glioblastomas, which you've heard in the media. John McCain had it, Ted Kennedy had it, Johnny Cochran had it. And unfortunately, it's a very lethal, or can be a very lethal disease, despite our most modern treatments. But that being said, all of us are working very hard to improve the outcomes of patients with gliomas. And then there are other gliomas like oligodendrogliomas, which can have exceptionally great outcomes with modern therapy, including surgery, chemotherapy, and radiation. And then all those different lesions that you see listed there. But for the most part today, we'll be talking about glioblastomas as well as some low-grade gliomas. And when we look at an MRI scan of a glioma, a tumor that starts in the brain, it can look a couple of different ways. So on this left panel here, you see a grade 2 glioma, and what's notable about it is that it does not enhance, and there's very little swelling in the brain. As you get more aggressive in appearance, the tumors start to enhance. Enhance means that they light up with a dye that you get during your MRI scan. And the dye indicates the area of the tumor. And then the dark stuff around this bright area here on the MRI scan is consistent with swelling and infiltrating tumor. When you look at the tissue, once it's removed in the pathology lab, what you see is dependent on the grade of the tumor. So for lower grade tumors, we have increased cellularity, it's called, more cells. But then as it gets more aggressive, we see increased numbers of cells that vary in shape. That's a sign of some cancers, is that the cells start to take on different architectures. And then as it gets to glioblastoma, you start to see what's called necrosis, which is areas of death within the tumor, lots of cells, and then something called microvascular proliferation, which is where you've got budding blood vessels within the tumor because the tumor is trying to survive by growing blood vessels to supply it. And, as you can see there, when you take all comers, statistically, those are the survivals you see. But every patient is unique when they come to us with a glioma. No one's ever had the glioma that they particularly had because of the unique genetics of that tumor. And no one will have that same glioma afterwards. That's something I tell patients all the time, which means that we can see patients who have excellent outcomes after glioma diagnosis and those that don't have such great outcomes. And I think it's incumbent upon us with both the research and the treatment algorithms that we have to be very thoughtful and individualistic in terms of how we counsel and treat our patients. Now, interestingly, once we take out the tumor, and this is the part that becomes very sciencey, is glioblastomas are very heterogeneous, meaning that, as I mentioned, they're not all the same tumor. So gliomas can fit in, if you profile gliomas by protein expression, they can fit multiple different types, what we call proneural or mesenchymal. And it's not important necessarily to remember all of that, but what is important is to understand that no two gliomas are the same, as I mentioned. And so why that's important is because with the current research we're doing, we're trying to understand which patients in which buckets, when we classify gliomas, will respond best to certain therapies, because we have a lot of available therapies, both in the FDA approved regions as well as the experimental avenues. And we're still trying to figure out which therapies are best for each patient. And so understanding the genomics of a tumor is incredibly important towards individualizing our care. And this requires taking the tumor from the pathology lab and sequencing it either at an academic institution like Cornell or through third-party vendors that you can send your tissue to, like Foundation Medicine as an example. The good news is we can, even if you're in a resource-constrained environment, you can get a lot of that information through standard, what we call immunohistochemical analyses, which can be done in any pathology lab. And that can often predict which protein expression or which genomic cluster that particular tumor will belong to. So I don't want to belabor the point, but the point is that you can make good predictions based on standard information that you get from most pathology labs. And similarly, these things that I'm talking about are not just academic. They're not just something that's interesting for scientists to know. What type of genomics your tumor has really influences the outcomes when you look at large statistical populations of people. So there's a thing called MGMT, which is an enzyme that helps repair DNA damage, and whether it's methylated or not, that's a protein modification that can happen to these tumors. Your survival can be different, even though the tumor looks the same on an MRI scan. And that's in this left panel here. Similarly, there's a mutation called the IDH mutation, and that stands for isocitrate dehydrogenase. And basically, tumors that have this mutation tend to do much better than tumors that don't. But that being said, once we know, for example, that someone has an IDH mutation, there are, for example, medications in the experimental area targeting that that are ongoing. So, you know, again, this genomic information is critical towards the modern management of gliomas, and so we advocate for that very strongly. Similarly, with oligodendrogliomas, as I mentioned before, they have really an excellent prognosis nowadays. As you can see here, this trial, which was a landmark trial, RTOG 9402, which is a multi-institutional worldwide study, they deployed PCV, which is a type of chemotherapy cocktail, with radiation therapy. And you can see this difference in survival curves between the two. So now this has really become the standard of care for patients with oligodendrogliomas. So what's the role of surgery now that we've looked a little bit at the science? Well, the role of surgery, if it's safe, is to try and remove everything we see that's enhancing. That's the part of the tumor that I mentioned lights up. For lower grade tumors that don't light up, what we want to do is remove all the abnormality that we see on the MRI scan. And our goal is to reduce it to the lowest possible number. Now, we can't cure these tumors with surgery. It's important to realize, because the tumors themselves, while they look like a mass on the MRI, and they are, there'll be infiltrating or invasive cells in the surrounding brain. And those cells we can't keep removing, because okay, sorry, I got muted there for some reason. So again, we can't remove all those invasive cells because that would cause a lot of neurologic problems, either in thinking, speech, movement, et cetera. So we reduce everything we can that's safe. And so we have some evidence in our literature showing that that is really what we need to do for, number one, to promote survival, because we can see that just by removing most of the tumor, we get a good, important survival benefit. And in some of the studies now, one of the more recent studies, we look at using fluorescent dyes to help visualize tumors, and that helps to distinguish tumors from normal brain. So one of the most amazing new inventions is something called Gleolan, which is known as aminolevulinic acid. And what that is it's a drink that a patient drinks before surgery. And basically, it's a compound in the heme pathway that helps to make hemoglobin. It also is a precursor of chlorophyll in plants. And in tumor cells, it accumulates abnormally. And when it accumulates and you give this drug, it starts to fluoresce or light up. And so what you see in this picture here is tumor that's purple or pink in color, distinguishing itself from normal brain around here. And so the purpose of this intraoperatively is to help us remove all the pink tumor without injuring or taking out normal brain. And so in the first study of its kind, now more than 10 years ago, 14 years ago, they showed that when you do resections, removals of glioblastomas with this substance, you can improve the outcomes in these patients in the long term. So that's really exciting stuff, and stuff we're doing routinely here at Cornell. And there's a lot of stuff coming down the pike, including photodynamic therapy, where basically you use the introduction of this accumulated substance to help Trojan horse in another therapy that can help selectively target tumor cells. And interestingly, again, with surgery, what we can see is that the molecular subtype, I mentioned IDH before, that can help influence what you do in your surgery. So in this particular study, which was published out of Harvard, when you had an IDH wild type tumor, if you resected everything that you saw, not just the enhancing disease, but again, the part that lights up, in addition to the swelling around the tumor, for IDH mutant tumors, you really saw a good benefit. But for tumors that were IDH wild type, you tend to not see the same benefit. So that's why it's really important to work with, have these kinds of tumors evaluated at centers that have a lot of experience and good surgical outcomes, so that you can have the best possible result with the surgery. Now, with low-grade gliomas, those again are a less cancerous version of glioblastoma, surgery is still key. And I think this was really brought to bear a number of years ago when they looked at this study out of the Scandinavian countries. And there was a bias towards just watching or observing in one part of the country versus being aggressive and removing those tumors in a different part of the country. And then they followed those patients over time. And what you can see is in green, the patients who where the tumor was removed, the lower grade tumors, had much better outcomes relative to those patients who were only observed. And similarly, when you look at multiple other retrospective studies, these are retrospective, of course, refers to tumor studies that look at patients in the past. Patients who had gross total resections or large resections did better at 5 years than patients who did not. So that's important information for patient counseling. Similarly, we know that in terms of the things that influence outcome, again, gross total resection, the ability to remove all the tumor that you see, is very important. And however which way you slice it, whether it's gross total resection versus subtotal, whether it's gross total versus having just a little bit of residual, your main goal with all these things is to remove everything you can see if it's safe, and really leave very little behind. This is even true for reoperated gliomas. So this is a study that we did several years ago now that looked for patients who had a recurrence of their low-grade glioma after surgery. And even if you take all the different chemotherapies, experimental therapies, clinical trials that they went on, if you were able to remove everything and not leave a site of any disease on the MRI scan at the end, you saw much better outcomes. So basically, it's not just gross total resection, it's do you see any residual tumor at all, even if it's tiny on the scan. And in those cases, we saw much improved survival in those patients who had no residual disease at the end of their operation. How do we achieve these kinds of results intraoperatively, safe, good oncologic results? Well, we use a lot of adjuncts. One of the things we use is navigation, where we can point to an area on the brain and know exactly where that is on the surface. And the way that happens is you get an MRI scan the morning of surgery, and then we register to your head while you're in the operating room. So we can again point and see where exactly we're looking at in the brain, and then develop a trajectory to tumors. So as you can see in this picture here, there's a tumor colored as orange, and we pick the least, you'll have to take my word for it, of course, least traumatic point of entry into the brain and to get out and to be able to take out this tumor. And what you can see in this topographical reconstruction of the brain is the gyri, those are the folds of the tumor, and then the sulci, the spaces in between them. And so here we're basically demarcating an entry point within the sulcus that's between the folds of the brain in an effort to minimize the disruption to the brain when we take out a tumor as visualized there. The other thing we do a lot of is something called brain mapping, and that's where we use electrical current to inhibit or stimulate cortical or subcortical function. And the reason we do that is everyone's brain is just a little bit different when it comes to where these functions are located. And in addition, with tumors, those functions can move, they can be distorted in terms of where they're located. And so when we're doing the surgery, we want to know exactly where those things are so that we can avoid them and protect them while still removing the tumor. So the history of brain mapping is actually amazing. And I encourage any of you who are interested to look some of this up, but it was really invented in the late 19th century in the context of patients with seizures. And if you can imagine in areas where anesthesia was still in its primitive state, you know, they were doing craniotomies for patients with certain brain conditions, which is, again, fascinating. But then in the 50s, 40s, 50s, it started to become more modernized with Wilder Penfield. And then I had the great opportunity to work with George Ogeman at the University of Washington, Seattle, who's really the father of modern brain mapping in many ways, who invented his eponymous stimulator, which we use to this day in the operating room. And essentially we apply safe, low dose, low voltage electric current to the brain while patients are awake to find areas like speech, again, so that we can maximize our tumor removal, but still preserve critical neurologic function like speech. Now, before we get to speech, the brain is topographically very interestingly organized when it comes to how motor function, that motor means the ability to move, is organized in the brain. And so it's actually referred to as the homunculus, the motor and sensory homunculus. And this is how on the brain, the motor function is laid out. So if you look, the face has a lot of representation in the motor homunculus, as well as the muscles for speech and tongue movement, as you can imagine. That requires a lot of cortical brain horsepower to speak. And so there's a lot of brain attention devoted to that. Your hand has an enormous amount of brain attention devoted to it because, again, of all the fine movements we use with our hands. And so if you were to reconstruct a human based on its topographical representation in the brain, the amount of effort the brain expends on certain functions, then a human might look like this, with huge hands, huge head, tongue, things like that. So that just goes to tell you how important the brain looks at certain parts of the body. Now, again, with regards to awake language mapping, similarly, there can be a lot more variation than there is in the motor functions. And this was a classic paper from 1989 from George Ogeman that I mentioned, where he found really disparate representations of critical speech functions in the brain, all throughout the frontal lobe and temporal lobe, which tells you how important it is to map the brain so that we can find where critical speech functions are located. You know, there's this distinction between positive and negative mapping. And what we know, positive mapping means we actually find a site where speech is arrested during surgery. And I'll get into exactly how that works in a second. Negative means that we don't find anything. And there was a debate in our literature for a long time. Do you need to find it? Or if you don't find it, is it safe to proceed? It turns out if you don't find it, it's safe to proceed. And so that's a real benefit to patients because it means that the surgery, the incision and the craniotomy can be a lot smaller. So just as in the case examples, you know, these are two patients, one's 29, one's 30. And this poor young woman was unfortunately misdiagnosed as having schizophrenia because she was having auditory hallucinations, but really she had a glioma in her posterior temporal lobe. And another woman, again here, with seizures, and they both had gliomas. This is an area called the insula. And this area is tricky to remove in both cases because it's an valuable real estate of the brain. Speech function is located around both those areas in very critical areas. And in particular, on this tumor here, it's located to all the parts of the brain necessary for movement of the right side of the body. And so we can remove those things, but it requires a lot of tricks, and I'll show you a video of one of the surgeries in a second, but mapping is a critical portion or a critical part of how we remove those tumors safely. So this is an old picture. This is like very, very old, but basically this is what the brain looks like in the operating room. I apologize if it's a little too graphic, but basically when we're mapping the brain while the patient's awake, we find exactly where people are hesitant with their speech, where they don't stop talking, and where the movement of their facial muscles occur when we perform speech mapping. On the right here, you can see what's called a tractographic atlas. So we can make these pictures of all the cables that connect the different parts of the brain. And when we do that, we can identify trajectories to tumors so that we minimize disruption to the brain, as I mentioned. And so this is just a picture of other tractographic atlases in the brain. There's the anterior thalamic radiations, the cingulum, et cetera, et cetera. And so again, all these are cables that connect different parts of the brain. And so when you think about it, the reason we have all these things and the things that make us so human is our ability to integrate concepts. So we have our prefrontal cortex, which is involved in decision-making and things like that, that makes us exquisitely human relative to other animals out there. And that's connected with motor areas, with sensory areas, with language areas, as you can imagine. And so it's an intricate and seemingly impossible to discern entanglement of cables that connect all these things. And so our role as neurosurgeons is to disrupt that as little as possible so that patients can have, again, the best possible outcomes after a surgical intervention. And it's really amazing that we have this technology nowadays and that we can do these kinds of operations to patients and they can leave the hospital in a day or two and go home. So this is what it looks like after the surgery. And you can see this is just, the white stuff is now just blood products. But the tumors have been removed. And in this case here, we've not caused any ischemia or strokes to the surrounding brain, which again is our goal. In terms of why mapping is so important, this meta-analysis here looked at patients who had late severe neurologic problems from a surgery. And you can see in those surgeons who did not use mapping, and had tumors that were located in sensitive areas, like for speech, there was a significant rate of speech deficits in the long term. Whereas with patients who had speech mapping, the outcomes were really quite excellent. So what I'll show you next is a video of one of the procedures. So just give me a second here. So here, so Roseanne, please interrupt me if you can't see it, but this is the brain here that's all labeled. And this is an area of the brain called the insula, again, which is a complicated area because, and I'll stop this for a second, speech is located here and here. So you have to create a corridor. There's a natural corridor called the Sylvian fissure that separates the frontal and temporal lobes. So you can use that natural corridor to remove the tumor. Now, the tricky thing is that in addition to protecting these areas of brain, you also have to protect these arteries which supply the internal capsule. And those are arteries that control movement of the right side of your body. And so what you'll see next is the surgery we did and how we have to work in order to remove these tumors. So here again is the tumor right here. And now we're looking at the brain using operative magnification, and we're using operating microscope and microdissection to enter that corridor between the frontal lobe here and the temporal lobe there. And again, we have to carefully separate the frontal and temporal lobes. This is the MCA artery. So this is a critical artery that supplies all the blood flow to the left hemisphere, which we can't injure, but we have to, expose it so we can do the work we need to do. And then if we skip forward a little bit, now we're doing something, the mapping. So that probe that you just saw there was used to stimulate the brain while the patient was awake. And then while they're speaking and talking to our neuropsychologist, we start taking out the tumor, which is located here. But at the same time, we have to preserve all these vessels. This is one vessel here. We start removing the tumor. Let's fast forward a second. And again, we're working, this is an ultrasonic aspirator. This pulverizes the tissue with high energy ultrasound and then resects it. And we work again in between these vessels to preserve blood flow into the tumor. So if we go forward a little bit, now we use a special medication called papaverin, which keeps the blood vessels open. And you can see we work in between all those vessels, remove the tumor. And then the post-op scan, you can see the tumor has been removed. And there's no ischemia to the surrounding brain or bright stuff that signifies stroke. And the patient did great, was able to leave the next 2 days after the operation and go home. So what's coming down the pike for patients with glioblastomas? So there are a number of clinical trials that we've run before and clinical trials we're working on developing now. Which I'll talk about in a second. But one of the ones was using, one of the things that I'm particularly interested in is using viruses to help treat these tumors. And so one of the trials we ran over the last few years is through a company called Tokagen. And we use specially engineered viral vectors to infect tumor cells. And essentially the way it works is that it inserts a gene into tumor cells called cytosine deaminase. And that gene converts a prodrug, which is an inactive form of a chemotherapy, into an active form. And by selectively transfecting tumor cells, when you give the drug via pill, it doesn't cause any side effects in the rest of the body, but only causes tumor cell death in the tumor cells that have been injected with this virus. So it's a very elegant system. Unfortunately, the trial was closed last year because it didn't work in a clinical trial. We did not find evidence that the virus, effectively cured these tumors in patients. And so it's unclear why it didn't work. There's a lot of post-hoc analyses being done to try and figure out why and figure out which patients had the best responses, but more to come on that. Another trial where we've seen some interesting results is again using a different type of virus, a modified cold virus, and it's been engineered to attach to a certain integrin, which is a type of carbohydrate on the surface of tumor cells. And then it basically targets these cells by prohibiting them from dividing and spreading within the brain, number one. But number two, it also invites inflammatory cells like your immune system to come attack these tumors and take care of them, because immunotherapy, as many of you have heard, is the holy grail of cancer therapy, having the immune system rid your body of these cancers. And oftentimes, we don't know how often, but oftentimes your body does that anyway. When you have a random cell that turns cancerous or is not working, your immune system will take care of it and clear it. But for whatever reason, sometimes cancer cells escape immune surveillance and don't clear the tumor. And so the concept of immunotherapy is to jumpstart that process so that patients can do that. And so again, we inject this virus into the tumor, we combine it with immunotherapy, and we've had some good results, which we're reporting at SNO, which is a Society of Neuro-Oncology meeting. And the bottom line is, in patients who had recurrent glioblastoma, we were able to see a few patients who had complete responses. So this is really, complete responses mean no observable tumor, over a significant period of time. So this is really encouraging results. It's not a cure, but this is really, if this bears out, a significant improvement over what we have. In terms of new ideas that I and others are working on, immunomodulation for brain tumors and gliomas is something that I think is really important. And I'm in talks with a certain pharmaceutical company at this point to combine a number of immunomodulatory agents in recurrent glioblastoma. And I hope to be able to report that that's going to get launched in the next couple of months, hopefully. Another area that we're looking at is MRI-guided focused ultrasound. This is a machine that we have at Cornell here in New York City. My partner, Mike Caplet, is a pioneer in the use of MRI-guided focused ultrasound for the treatment of neurodegenerative disorders like Parkinson's and essential tremor. But we're trying to see if we can use the same device to help patients with glioblastoma by using its technology to get certain drugs into the brain that otherwise wouldn't get there. The brain has something called the blood-brain barrier, and it prevents many chemotherapies from getting into the brain. And so what ultrasound can do is temporarily open that blood-brain barrier and thus allow chemotherapies to enter that otherwise wouldn't. So we're in the infancy of that technology, but we're excited to see where that goes. So I'm going to pivot here to brain metastases. Now, what are brain metastases? Brain metastases are basically the spread of a cancer like a lung or breast cancer into the brain. And so we have to be very individualistic, just like with gliomas, with how we treat these patients with brain mets, because we really want to preserve not just length of life, but quality of life. And typically, the most common tumors that go into the brain are lung, breast, melanoma, and renal cell. But nowadays, because some of our chemotherapies and immunotherapies and targeted therapies for any cancer have gotten so good and patients are living so much longer, we are seeing the development of mets to the brain from other cancers like ovarian cancer, which we never used to see. So, you know, I think where we are currently is a testament to the efficacy of modern chemotherapy and immunotherapy, but also a reflection of the fact that we don't have therapies that all get into the brain. And so we have to be strategic in terms of what we deploy. In terms of how the challenge, one of them is the blood-brain barrier, as I mentioned. And the other thing that I've been a big proponent of, as many others in the field, is that we don't lump all brain mets together. A patient with lung cancer is very different from a patient with breast cancer. And in the past, in the 80s, 90s, early 2000s, most studies lumped anyone with the brain metastasis together as if they're all the same, but they're not. And we have particular therapies we can use for one type of tumor versus the other. Prognostication is really important for surgical decision-making. I'm just going to skip through this in the interest of time. But the one we currently use is something called a GPA, like grade point average, but this is graded prognostic assessment. And this is really a more modern, the most modern prognostic tool we have. And to my point earlier, it's really based on the type of cancer that you have. So whether it's lung, melanoma, breast, renal cell, et cetera, we take certain factors like the tumor subtype of the patient, whether it's, for example, an ER positive, HER2 negative tumor. Those factors, estrogen positivity or HER2 positivity, are important in determining what chemotherapies you might get from your medical oncologist. KPS refers to Karnofsky performance status. That's just a reflection of how well you're doing, how independent you are with your activities. And then age, whether it's 1950 or 2020, your age can really influence how you respond to therapies. But nowadays, we're hoping that with all these new therapies that we have, whether it's immunotherapy, targeted therapy, et cetera, age will be less of an issue. And really, it's mostly a reflection of your physiologic age. How healthy are you going into a cancer diagnosis that determines or influences your prognosis. So the things that drive survival in patients with brain metastases, for the most part, are how well you are or how healthy you are coming in, your age, and then the number of brain mets that you have. And the reason that we spend a lot of time thinking about prognosis and your disease burden overall when you have cancer is it can fundamentally alter our treatment decisions. So if you look at this one MRI scan, you can have multiple different patient presentations. So what this shows is a patient with a solitary brain metastasis. And if, as they often are, patients come in and they look otherwise perfect, the best treatment for this by far is surgery, followed by something called radiosurgery, which I'll talk about in a second. If, on the other hand, the patient is really sick, unable to take care of themselves, et cetera, of course, this is the fourth panel here I'm pointing to, then of course we're not going to put them through an operation because it doesn't make much sense. So, there are lots of options in between surgery and no surgery, including medications. But the bottom line is you want a multidisciplinary team, which includes not just your surgeon, but a radiation oncologist, medical oncologist working together to determine the best avenue of care for you. In terms of the goals of brain metastasis treatment, we want local control. That means we want to make sure it doesn't grow back in the area where it's located. We want to make sure we have no new brain metastases elsewhere in the brain. And then we want to improve symptoms, of course. And all those things don't need to be mutually exclusive. We need to do all those things together. In terms of treatments for brain mets, we have a lot, and a lot more than we had even 5 years ago. And this is well laid out in a recent publication we put out, which is available on Amazon for anyone who's interested. Please email me after the talk. I'm happy to try and get you a copy. But the treatments can range from just observation for small asymptomatic mets to whole brain radiation therapy. We tend not to do that very often because it can be involved in some cognitive deterioration. Surgery, which is again removal of the tumor, radiosurgery, that's focused radiation therapy to the tumor, which can be done without an actual open surgery. There is also chemotherapy and targeted therapy. So there's the Landscape trial in patients with metastatic breast cancer that were HER2 positive, and they found a great response rate, almost 70% in the brain when they use lapatinib and capecitabine. So that's just sort of the the firing gun, as it were, of the new era we're in, where we're going to have so many more options, hopefully, for patients with brain metastases that don't involve radiation, that don't involve surgery. So that's really exciting. With melanoma, immunotherapy can be very effective in helping to treat these tumors, again, without surgery and radiation therapy. And then sometimes when all those things don't work, we have other options, including brachytherapy, where we implant radioactive seeds into the brain to help prevent recurrence of these tumors. The reason that tumors are harder to treat, or brain metastases are harder to treat sometimes relative to the primary tumor in the lung or the breast, for example, is that they're genomically different. And so there's been some really important research here. And I'm not going to belabor this slide, but basically what it shows is that the brain mets, which are these red lines, are genomically different compared to their primary tumor. And what this slide shows is that the brain mets themselves are similar to each other, which means that creates a window of opportunity that you can target brain metastases as a unit as separate from the primary tumor. And so the idea would be then that you can create additive therapies, things that might be working systemically may still be worth continuing. This is a hypothesis that many of us have, but that it may also be that you have to add therapy to help control the brain. And so a lot of work here, but for, more and more people are pushing, oncologists are pushing for biopsies for brain metastases so we can get some of that genomic information and thus, create more treatment options for our patients. The role of surgery in patients with brain metastases sometimes is diagnosis, but often it's to reduce the burden of tumor in the brain and relieve the mass effect and provide symptom relief. It also makes subsequent treatments, whether it's medication or radiation, much more effective because you're dealing with a much smaller level of disease in the brain. Good surgical candidates are those who are as physiologically fit as we can make them, but we all realize that sometimes patients with cancer diagnoses can, be weakened from their cancer and their therapies. And so that being said, if someone can tolerate an operation and it's their best option with all the different options that we kind of went through already, then we don't hesitate to recommend that if we think that's in their best interest. But we, of course, have to do a lot of coordination between the other therapies that we want to give patients because we're loath to stop other therapies like systemic chemotherapies during just to do in surgery. For some of the targeted therapies or immunotherapies, we often can continue them even through surgery, but that's on an individual basis. Now, surgery, is important to know. We, of course, believe that surgery needs to be safe, and the critical thing is to realize that it is safe. In our hands, when we look at our data, the risk of any significant problem with an open operation is less than 1%. And it's really great from the standpoint of patients because not only do you remove the tumor, but you get them off steroids. Steroids can have a lot of side effects, including temporary diabetes, mood issues, sleeplessness, things like that. But with surgery, you can get patients off all those medications quickly. Whereas if with other strategies, whether it's radiation or medication therapy, again, you need to be on steroids potentially for a while before you can come off them. And the longer you're on steroids, the more you might become dependent on them, et cetera. So steroids is just one small reason, but the other oncologic reason is that other therapies are more effective when we do surgery, combine it with, for example, radiation therapy. And we use many of the same techniques we talked about with gliomas. We use tractography to help map the brain. That's what this cable here is, the corticospinal tract. And that is involved in conveying motor function from the cortex to the spinal cord. So of course we want to know where that is so we don't injure it when we take out a tumor as described here. We can use LIT, which is laser interstitial therapy, where we insert small probes into the brain and then heat up the probe and burn the tumor. That's very minimally invasive and can be very effective for deep-seated tumors that are hard to reach otherwise. Brachytherapy, that's when we use radioactive seeds as pictured here. And those can be used to treat patients who have had surgery and radiation before, but the tumor has still come back. And then MRI-guided focused ultrasound, again, an experimental thing that we're trying to develop here at Cornell. Important, again, in terms of experience, is that when you take out these tumors, you want to make sure that you take them out what's called en bloc, if possible. And that's where you come around the entirety of the tumor and take it out as one piece. The reason is if you don't do that, you have an increased risk of local leptomeningeal spread within the brain, which is very hard to treat once that happens. So that's not the only reason that leptomeningeal spread can happen. That can happen anyway. But at least some of our data indicates that an en bloc resection can help prevent that as being a result from surgery. And not to belabor this slide, but the main point here is that local therapy, whether it's surgery or SRS, SRS is radiosurgery, which is targeted radiation to the area of the tumor, is the best at providing the best outcomes in terms of local recurrence. And that's what we do. Generally for patients, we either do surgery plus radiosurgery, which is surgery plus radiation, or just radiation alone. And radiation alone is often our mainstay for patients with brain metastases. We only really operate if and only if we can't treat it with radiosurgery. And that's usually when the tumors are too big to deal effectively with radiosurgery. But if we do radiosurgery after surgery, we can see excellent outcomes in terms of prevention of recurrence at the site of the tumor. We're almost done. I'll just go through some cases quickly. This is a 49-year-old gentleman with melanoma that I saw some time ago who had these two metastases, which were relatively asymptomatic. And so we recommended him for radiosurgery, which is, again, targeted radiation to the tumor. And but on the day of SRS, he came in complaining of some word finding problems, and lo and behold, his tumor had really exploded. And so this is not a good situation to just do radiation, and because he's so symptomatic, there's a ton of swelling in the brain, and these tumors are quite big. So what we did is we resected those lesions, took them out completely, and we're able to get him off steroids within 3 days. His speech returned to normal within 3 days. And then a week later, we treated him with radiation, and he did well for years, actually, after this. Similarly, this is a patient who's got a metastasis in the left frontal lobe, just in front of the part of the brain that deals with motor function of speech, the part of the brain that deals with movement of your mouth. And so we mapped that area. We mapped the area that's involved with speech production, both the motor part and the speech part, and we're able to take this tumor out. And again, the patient was able to go home quickly. So mapping, even in metastases, whether it's speech or motor, is a critically important modality to help remove the whole tumor, as well as to help preserve and restore neurologic function. If these tumors recur, we have salvage options. They include doing radiation again, laser therapy, and again, radiation therapy with brachytherapy, which are those radioactive seeds that I mentioned. The last thing I'll talk about, just in the interest of time, is a clinical trial that we're working on here that uses the abscopal response. And what that is essentially using radiation as an in situ vaccine, where we radiate one tumor in someone who has many tumors and then hope that the immune system takes over and starts attacking the rest of the tumor. And this is by combining radiation with immunotherapy, pembrolizumab in this case. And so, you know, again, nothing is foolproof, but this is a patient that we treated on this protocol, and we only radiated this tumor here in red. And what you can see, and we combine this with immunotherapy, and what you can see is that over time, these tumors that we did not irradiate here on the left panel all started to dissipate 2 months later on the right panel. And this is all across the brain. You can see these tumors started to go away on their own. And this is pretty magical stuff in the context of modern brain tumor therapy for brain metastases. So we're really excited about it, but this is obviously a trial that needs to work on multiple patients for us to say that it's really effective for everyone. So more to come on that. So, but that's again something we're really truly excited about. So in conclusion, whether it's a glioma or a brain metastasis, we want to individualize our treatment plan. We work as a team with a big group of physicians who are experts so that you have the options of the best possible care for your patients, the most modern treatment options. And, you know, clinical trials are key when certain therapies or standard therapies don't work. And whether it's clinical trials here at Cornell or anywhere else, it's important to have an oncologist who is plugged in everywhere so that they can refer you to the right clinical trials that make the most sense. For those of you who are interested in brain metastases, I'm one of the scientific co-chairs of the Society of Neuro-Oncology meeting, which was canceled this year, unfortunately, because of COVID, but we're hoping to have it again in 2021 in Toronto. So if anyone is interested, please let me know. And again, we have so many different tumors that we didn't get to talk about, which I'm happy to talk about at a different date. But you know, there's chordomas where we can use small little endoscopes and take them out through the nose. There are meningiomas that are very complicated that can be located at the base of the skull that we use special techniques to get to. But using modern techniques, we can remove these things without causing patient harm. And then acoustic neuromas that are involved in hearing, again, we can take those out very safely. And finally, pituitary tumors taken out through the nose, you know, minimally invasively. So my daughter says thank you, as do I. And please reach out to me. My contact information and office information is on the slide, and happy to get back to you. On the right are all the surgeons at Brooklyn Methodist that are part of the Weill Cornell Brain and Spine team. And with that, I'll open it up for questions. So thank you all for your attention.
There's a question in the chat box from Vikrant Setia. How do we decide what mets to be radiated?
Sure. Great. So I think in general, if someone has, it's dependent on a lot of factors. It's dependent on how many mets there are, whether we're going to try chemotherapy or immunotherapy or targeted therapy. So there's a lot of factors in play, and it's hard to answer that as sort of a blanket statement. But what I will say is that radiation or radiosurgery is often the mainstay of treatment. It's effective, it's durable, it's minimally invasive, and really is effective at controlling the disease. So, you know, if someone has 50 mets in the brain, then we're not going to do stereotactic radiosurgery at all 50. The option in that case becomes whole brain radiation therapy, or not doing whole brain radiation therapy. If someone has 50 tiny mets and they're asymptomatic, you know, I try and hold off on whole brain radiation therapy as long as I can and think about whether or not there's a systemic therapy that we can give that will, you know, potentially treat those tumors without radiation. So it's an individual decision in each case. Oh, sorry. it is in regard to trials. So the tumors for the trial that we irradiate are the ones that we think are most, either the biggest or potentially, if they were to grow, would be most problematic in terms of causing symptoms. So that's generally how we decide. The next question was, are there different symptoms for different tumors? Not so much by the tumor, it's just really where it's located. So if a tumor, regardless of what type, is located in the speech part of the brain, that can cause speech symptoms. And so really it's more a reflection of where the tumor is located, less so the type of tumor. The question was for MRI-guided ultrasound for Parkinson's. Can you tell us more? So my expertise is not in Parkinson's essential tremor, but yes, for symptoms of those disorders, for symptom management, focused ultrasound can and is becoming an amazing treatment that doesn't require surgery. So for years, deep brain stimulation, DBS, has been used in neurosurgery, where we make small incisions on the scalp and drill a hole and put in these electrodes into the certain parts of the brain to help reduce the symptoms of Parkinson's or essential tremor. Now with ultrasound, we can potentially achieve the same outcomes without drilling the hole and putting in a permanent electrode in the brain. So if you're interested in that, I would encourage you to look up Mike Caplet, who's my partner in the Department of Neurologic Surgery, and you can read more about the work he's doing. Our website also has a wealth of information on the subject.
So if there are no more questions, I think we'll end here. Oh, sorry.
Yeah, I think there's one. What trials are available for recurrent glioblastomas? Well, there's really a lot. And many of them are Cornell, many of them are other institutions. So, you know, I can tell you that the ones I tend to be focused on are on some of the viral immunotherapy trials, which I discussed. We're hoping to open a phase 3 trial using the adenovirus-related vaccine, oncolytic vaccine, based on some of the results that we've seen thus far. We're hoping to open a new trial for newly diagnosed glioblastomas, again, which uses tumor lysate, which is taking the tumor out of your head, exposing it to circulating immune cells, and then hoping that those immune cells then go back and attack your tumor. And then, of course, there's trials in lots of other places. So the important thing is, if you're interested in trials, is that you just work with a dedicated neuro-oncologist who has a lot of experience and understands what trials may be best for you, either at Cornell or other institutions in the city or nationally.
So if there's no more questions, we'll end here. Thank you, Dr. Ramakrishna. This presentation will be available on YouTube in a few days. Have a nice night.
Thank you, everyone. It's been my pleasure. Hope you found this enjoyable. Take care.